Bipolar and related disorders. So our objectives are to identify behaviors, treatment modalities, and our desired nursing outcome. So how do you know if you're just having mood changes or you actually have a mood disorder? So work and family and social responsibilities drive most people to go through their daily routines knowing that their mood and feelings will pass. Mood disorders are diagnosed when a person's alteration in emotions are persuasive and interferes with the person's ability to live life. So everyone has highs and lows, but when you have extreme lows and extreme highs and it is affecting your life, you're unable to function and to concentrate and to make sure that your daily life activities are functioning, then it's a possibility you're experiencing a mood disorder. Mood disorders are also known as affective disorders, which are emotions ranging from depression to mania or possibly both. There is no cure for mood disorders, only treatment. Mood disorders are the most common psychiatric diagnosis associated with suicide, and depression is one of the most important risk factors of this disease. Sometimes your patient may feel like they're on top of the world, and after a few days, they feel euthymic, which is an average effect and average activity. Okay, so we're going to talk about the types of behaviors. So we have depressive disorder, which are 2 or more weeks of sad mood or lack of interest in life activities. It interferes with appetite, sleep, work, and overall enjoyment in life, which people experience a depressed mood or a loss of pleasure in nearly all activities. The person may experience a change in their eating habits, unexplained weight gain or weight loss, increase or lack of sleep, impaired concentration, impaired decision making, impaired problem solving abilities, and ability to cope with daily life, feelings of worthlessness, feelings of hopelessness, guilt, despair, thoughts of death or suicide, overwhelming fatigue, and rumination with pessimistic thinking and no hope of improvement. Bipolar disorder, which is also formerly known as manic depressive illness, is characterized by periods of highs, which are mania, and lows, which are depression, after periods of normal behavior or normal mood. Bipolar disorder is diagnosed for a patient with mood fluctuations from one extreme to the other, from mania to depression. And mania is described as a distinct period in which the mood is abnormally and persistently elevated, expansive, or irritable. We will discuss the related mood disorders on the next 2 slides. Dysthymic disorder is a chronic depressive mood for most of the day, lasting at least 2 years. But this disease is not severe enough to warrant hospitalization or to be diagnosed as major depressive disorder. Patient has sadness, low energy, but not to the point of decreased functioning. Long-lasting symptoms, but are not disabling. Cyclothymic disorder, which is a chronic mood disturbance which lasts at least 2 years, and it involves both hypomania and dysrhythmic mood swings. Mood swings do not warrant hospitalization and they do not impair the person's functioning. Seasonal affective disorder. Recently studied syndromes that appear to affect most women and are characterized by hypersomnia, so increased sleep, fatigue, weight gain, irritability, interpersonal difficulty in the winter months. Successfully managing daily treatments of 2 to 3 hours of bright light. Depressive personality disorder. Feelings of rejection, gloominess, depressed cognition, overly serious, no sense of humor, can't enjoy life or relate broad and worry, low self-esteem, and pessimistic personality. Postpartum or maternity blues are normal symptoms that begin one day after delivery and peak 3 to 7 days, then subsides, characterized by labile mood and affect, crying spells, sadness, insomnia, anxiety. No treatment is typically needed. Postpartum depression does meet the criteria for major depressive disorder, and the onset is usually within 4 weeks of delivery. Postpartum psychosis is when a psychiatric episode with depressed mood, rejection, and decreased interest of baby or in the baby, followed by subsequent feelings of guilt or unreasonable fear that something will happen to the baby. Affected women usually improve within 2 to 3 months of treatment. Treatment depends on the individual's symptoms, and women with psychiatric history are more at risk for postpartum psychosis. So the nurse must continually assess for risk of suicide or infanticide with these individuals with postpartum psychosis. People diagnosed with depression are at risk for suicide, at risk for imbalanced nutrition, sleep disturbance, anxiety, ineffective coping, hopelessness, ineffective role performance, social isolation, and chronic low self esteem. So, our outcomes or what our goal is for the patient is for the client not to harm themselves or others, to carry out activities of daily living independently, to establish a balance of rest, sleep, and activity, to establish a balance of adequate nutrition, hydration, and elimination, evaluate self attributes realistically, socialize with staff, peers, family, friends, return to occupation or school activities, comply with medication regimen, verbalize any symptoms of reoccurrence, and etiology. So biological theories include genetics, so mood disorders may run in families, neurochemical theories, so deficiency in serotonin, norepinephrine, or acetylcholine may these fluctuations may cause the depression to happen. Also, 5 to 10% of the people with depression seem to have a thyroid dysfunction. Psychodynamic theory tends to blame patients and families for illness and are not regarded much anymore. So Beck is one exception who views the depression as a result of specific cognitive distortions in susceptible people. Started with the concept of cognitive therapy, which is still widely used today. So some of the nursing interventions will include providing the client's safety and safety of others, promoting therapeutic relationships, therapeutic activities, promoting daily living, activities, daily living, and just general physical care, promoting therapeutic communication, management of medications, providing the client and family with teaching. So those are some of the nursing interventions for our depression diagnosed clients. So some of the symptoms associated with depressive disorder include changes in eating habits, sleeping pattern, which we discussed some of these on our previous slide, so we won't go through each and every one of them. But you do want to make a note that their concentration and decision making is impaired. They have problems coping. Sometimes they feel like they're worthless or hopeless, or they may have guilt from a past decision or something that occurred in their life. They may have thoughts of death and suicide, so it is very important to do a suicide risk assessment when you are doing a psychosocial assessment for your patient. In any event that they identify positively with your suicide assessment tool, you must report that. You are a mandated reporter and you must report that. And our goal is to then put them on suicide watch and whatever your facility's policy is, which is usually a 1-to-1 if they have a plan, and if they do not have a plan, it's just a frequent watching of the patient. So it might be every 10, 15 minutes, someone's making rounds and checking on them. So you must know that they may have negative thinking. They may feel overwhelmed with tiredness and fatigue as well. So let's review some key factors about depressive disorder. So major depressive disorder, along with anxiety disorder, is the most common psychiatric diagnosis. And there is still a stigma that exists that if a person has a diagnosis of depression, that they are considered weak. Only 12% of the people are willing to take their medication, whereas 70% of the patients will take medications for a headache without any problems. But because of the stigma, a lot of patients are non-compliant with their medications. And therefore, our disease is definitely underreported, underdiagnosed, and undertreated because of the stigma associated with depression. So 9.5% of the American adults have a diagnosis of depression. And depression often begins between the age range of 15 and 30. It can appear in younger children as well. So you just got to recognize the signs of depression. Depression is the leading cause of disability among men and women in the US and worldwide. And depression is the most common diagnosis associated with suicide, twice as much for women as men. Some cultural considerations: depression may be masked by other symptoms. Children may present cranky, have school difficulties, school phobia, failing grades, learning difficulties, or show antisocial behavior. Teens may engage in substance abuse or risky behaviors. Older adults may become argumentative and non-compliant. Some somatic complaints may accompany depression. Specific cultures may identify certain complaints. So according to your textbook, Asian culture, they may identify with a headache or a backache. Latinos may identify with having bad nerves, and according to your textbook, Middle Eastern culture may complain of heart problems. Psychotherapy in conjunction with medication is considered the most effective treatment. Useful therapies include behavioral, cognitive, interpersonal, and family therapy, depending on the client's needs. Electroconvulsive therapy, or ECT, is still used if the medication is ineffective or the side effects are intolerable. Anesthesia and muscle relaxants are given to the client before administering electronic shock, which produces seizure activity in the brain, and these treatments are done in a series. For instance, they may do it 3 times a week for 6 weeks. And pre and post treatment of a patient receiving ECT is similar to a minor surgery. But you can expect that the client will have short-term memory loss, confusion, headache, and drowsiness upon completion of ECT. Antidepressants are used, so we have SSRIs, and the side effects for these drugs can vary, but they are known to cause insomnia, weight gain, sedation, constipation, nausea, and they are usually prescribed for mild to moderate depression. So then we also have TCA antidepressants, and these drugs are will not begin to become effective until 4 to 6 weeks after starting. They are usually used for moderate to severe depression. And then we have atypical antidepressants. And some of the side effects for these drugs include headache, dizziness, drowsiness, nausea, vomiting. And for trazodone, which is sometimes used for insomnia, because it has a sedative effect. MAOI drugs or antidepressants. So they interact with foods that contain termine, so which was mentioned in our psychopharmacology lecture. So aged cheese, chocolates. So you just want to make sure your patient knows about this, and in the event that they eat the wrong foods, it could cause a hypertensive crisis. And they interact very unfavorably with some over-the-counter prescription or over-the-counter drugs and prescription drugs. So they are lethal. MAOI antidepressants are lethal in an overdose. So you want to make sure you assess your patient for suicide risks carefully. Make sure they do not have a risk of overdosing, because if they do take these medications, it can be lethal. It can be lethal. They take them out, not as prescribed. So the maximum effectiveness takes 6 weeks for these drugs. Some of the side effects include dry mouth, blurry vision, constipation, urinary retention, weight gain, sedation, orthostatic hypotension, and nausea. Patients diagnosed with bipolar disorder are at risk for violence, injury, imbalanced nutrition, ineffective coping, noncompliance with medication regimen, ineffective role performance, chronic low self-esteem, disturbed sleep patterns, fatigue, and self-care deficit. So some of our goals for our client would be to remain safe, to establish a daily routine which incorporates rest, sleep, and activity, to establish adequate nutrition, hydration, and elimination participate in self-care activities, evaluate oneself realistically for their personal qualities, as well as engage in socially appropriate activity, and have their actions be based in reality, verbalize knowledge of illness and treatment. So for etiology, um, family genetics play a part. So if one family is diagnosed with bipolar disease, the child has a 25% chance of developing it. If two parents are diagnosed with bipolar disease, the child has 50 to 75% chance of developing bipolar diagnosis. Neurochemical imbalance is a possible cause for bipolar disease as well. So, excess of serotonin, dopamine, norepinephrine, or acetylcholine is believed to have effect on the development of this diagnosis as well. Neurotransmitters are supersensitive to transmission of impulses. Anticonvulsants may work because of this. So one study showed that people with bipolar disease have 30% more neurotransmitters in part of the brain, which may cause overstimulation. So genetic factors correlate between early bipolar onset and alcoholism or early alcoholism. So the higher rate of mixed and rapid cycling, slow recovery, more hospitalization tend to respond to anticonvulsant treatment as opposed to lithium. Psychological influences include inadequate coping mechanisms, denial of the behaviors, those who are abused and as a child or have early onset of bipolar and more rapid cycling. Psychodynamic theory may blame person or family, and the psychoanalytic theory may states that mania is a defense mechanism against the depression. So some of the interventions that we can provide as nurses are to maintain our safety as well as the safety of our clients. But always remember the client safety is number one priority. Meeting their physiological needs, provide therapeutic communication, promote appropriate behaviors, manage their medications, and you want to educate both the client and their families. Okay, some key factors about bipolar disorder. So there's a correlation between ADHD as a child and later developing a diagnosis of bipolar. So adolescents more likely to have psychiatric features, more common in highly educated people. Manic episodes may be precipitated by a stressor. Some people have 4 or more episodes of cycling a year, which are called rapid cycling. That's important. 50 to 70% of the time, major depressive episodes will occur immediately before or after a manic episode. When mania is accompanied by psychosis, it is more serious and more likely to lead to aggression or suicide. It is common to have a dual diagnosis with substance abuse. When substance abuse is involved, it tends to make the experience more of a rapid cycling. Many people with bipolar deny their mania, and so the prevalence is probably much higher than what is really reported or recorded. So here are some signs of bipolar disorder. So I will not go through this list. I believe we touched on several of these. but I want you to know that hypomania, which is not listed here, is a milder form of mania. So mania is extreme highs, depression is extreme lows, and bipolar disorder is diagnosed when the mood fluctuates between extreme highs and extreme lows, or mania and depression. Sometimes there could be a mix of both. Psychotherapy in conjunction with medication is considered the most effective treatment. Useful therapy includes behavioral, cognitive, interpersonal, and family therapy depending on the client's needs. Lithium is the primary treatment for bipolar. Regular monitoring of the serum lithium levels is needed. So some side effects of lithium include mild nausea, diarrhea, anorexia, fine hand tremors, fatigue, metallic taste in the mouth, polydipsia, polyuria. So the normal level for lithium is 0.6 to 1.2. Signs of lithium toxicity include severe nausea, vomiting, diarrhea, severe mental confusion. Onset of action is 5 to 14 days with a lag period. Antipsychotics, antidepressant agents are used carefully combining with lithium to reduce symptoms in an acute manic and acute depressive client. The half-life of lithium is 20 to 27 hours. So anticonvulsant drugs are also used as mood stabilizers. Some of their side effects include drowsiness, sedation, dry mouth, blurred vision, and weight gain. Treatment of bipolar disorder involves a lifetime regimen of medication, either anti-manic medications such as lithium or anticonvulsants used for mood stabilizers. This is the only psychiatric disorder in which medication can prevent acute cycles of bipolar behavior. Once thought to reduce manic behavior only, lithium and other anticonvulsants also protect against effects of bipolar depressive cycles. If a client is in an acute stage of mania and depression and exhibits psychosis, such as disorganized thinking as seen with delusions, hallucinations, and illusions, an antipsychotic agent is administered in addition to the bipolar medication. Some clients keep taking both bipolar medication and antipsychotic medications. Let's review some key points. So, there is a genetic component to mood disorders. Major depression is a mood disorder that robs a person of joy, self-esteem, and energy, and it interferes with relationship and occupational productivity. Some symptoms of depression include sadness, disinterest in previously pleasurable activities, crying, lack of motivation. Several antidepressants are used to treat depression. People with bipolar disorder cycle between mania, normalcy, and depression. Clients with mania have a labile mood and grandiose thoughts. So, in conclusion, after nursing interventions, the patient will acknowledge the mental illness and impact on their lives, demonstrate adaptive coping strategies, develop and demonstrate realistic goals for their future, Have capacity to work through feelings and anxiety, depression, and low self-esteem. Verbalize the desire and hope to move forward in life.